it is our desire that at the end of it all, the healthcare workers who have gone through it have achieved the competencies necessary to deliver on those services. So for every training, there is a standardized testing tools are used for assessing the individual's knowledge and skills before and after the training in ANC and PNC. And additionally, we also do the OSKIS, or the skills assessment, where the facilitators subjects are maybe just a random number of the participants in the skills assessment to see whether we are making progress. And all this information we are tracking to see how throughout the project, how the healthcare workers' competencies and skills are improving or otherwise. We have also we are also engaged in collecting data on applying standards-based audit for quality improvement. For those of you who have seen the manuals, you know the stages of quality improvement, that beyond discussing it as something, giving feedback to a facility following the training, the team is supposed to select the standard to be audited. They are supposed to undertake a baseline assessment of their facility, identify the actions they are going to follow, and then after implementing those actions, they are supposed then to do measurements and see whether they are making progress. And when they achieve their 80%, then they can move on to another standard. So the standards that are being used in the project facilities, they are heavily borrowed from the MNH, the national guidelines issued by the ministry, the standards of improving MNH quality of standard. And therefore, we are just helping to providing an approach on how to implement these guidelines, because one of the things that happens is that in most countries, sometimes we have policies done, we have a strategic document done, and even an action plan for something, but unless it is really taken to the frontline healthcare workers, we find that whatever has been proposed never really happens. And 5 years, 10 years down the line, we are even maybe at the level of reviewing what that document was supposed to achieve. But if it has not been disseminated, it has not been implemented, then it becomes impossible for anybody to determine the value. So for the project, we have come up with a dashboard that tracks the status of how the facilities in the project are implementing this standards-based audit, and we will be able to share that information in the presentation that will come under the impact of the project tomorrow. Some of the challenges that we have encountered, as I said, the scope of the project, of course, it is very small. When you're working in 61 health facilities in a country with more than 12,000 healthcare facilities, it is small, but it is not too small to generate evidence. So we believe that in as much as 3 counties, 61 facilities may look small, the evidence generated there can transform how we do things in MNH, especially in regards to the quality of care. Some of the challenges also encountered is staff turnover is high in some of the counties. You know, there is the routine, movement of staff. You can train somebody to be the one to do standards-based audit, but if that person moves to the next facility, then that facility is left without perhaps a champion, and therefore it will take time before another person is recruited. There is also persistent lack of key MNH equipment in some of the project facilities. So the small grant that provided some basic equipment did not address all the needs in the facilities. So it is still possible that a client can come to ANC and they find the BP machine is broken down, the EMOQ is not working or is not available. So as you can see, they will still not get the full complement of the services that they are supposed to get, and therefore they will be going back with partial service provision, which is basically poor quality services. So then conducting the quarterly M&E data collection, it is one of the things that we had not budgeted adequately maybe at the onset of the project, and we discovered that because of the vastness of some of these project counties, it is quite expensive to have somebody move from one facility to another to be able to collect the data. But this is something that perhaps maybe technology might be able to help us going into the future. And then when it comes to the blended learning, the blended learning that targets frontline healthcare workers, in some of these localities the internet is unreliable, and therefore people would like to log in or to do their SDL or to participate in a Zoom session, but if the internet is poor, then the person will not effectively participate in as much as they were willing and interested to learn, so they will not fully benefit from the session. However, there are still opportunities, and there are many. what we can say as a country is that this particular project on quality improvement through integrated HIV, TB, and malaria in ANC leverages national momentum and initiative on UHC and MNH-QOC and builds on the ongoing MPDSR institutionalization. As an organization, LSTM has supported the government at national and even at subnational level to do a lot of institutionalization of MPDSR, the audits, the mechanisms, the writing of reports, and all that. And this is just another element of quality dimension that is being introduced. And if we just pair these things, we can realize result. It also provides a window to support government priorities by developing and refining tools and approaches to QI at facility level. You will realize that yes, there is a lot of talk about improving quality, but the question is, what exactly are we doing at those facilities? Level 2 dispensaries, health center. What exactly are we doing to make sure that the quality is moving from what we've always known to another level if we have to change the indicators? And of course, the project has generated interest and it has opportunity for scale up. The neighboring counties, the people we've engaged in this project, they know about the project. They know, they can see that this project can make a lot of difference. In terms of sustainability, we've said that the project is not just a project happening out of context, but one is that it leverages the country momentum on UHC, which has quality as at the center of it. There is no UHC without quality. Beyond putting money and making sure that everybody has an insurance or some prepaid scheme, there is the quality of services matter. Otherwise, we will be where we were. And then the project interventions also complement the national guidelines on MNH, QOC, and the rollout of standards-based audit approach for QI provides the means for government to pilot its policy. So the evidence that we generate will really be very useful. The project geographic scope leverages other previously implemented projects. We were previously in the 3 counties, and so much had already happened. So the relationships and the work that was already done forms the foundation for this project. And also the tools in ANC and in QI, including the recently dashboard. Once maybe in another year or so, it will be something that we'll be proposing to the government to adapt to be able to track the quality improvement in the facilities. And it uses a cost-effective approaches. For instance, the use of blended learning. Instead of moving people from their facilities, they just take the training at their own time and maybe just set aside time for the Zoom session and the short face-to-face. So we also have success stories. We have success stories from Viga County where they've implemented standards-based audit. On one of the standards they selected around cesarean section, just telling mothers why they are being done a cesarean section. Initially it was at 63%, but just after 1 month of, healthcare workers being consciously going out of their way to make sure that anybody going for a cesarean section is told why and what are the implications, it moved to, 28 percentage points to 92%. That is really something. And of course, we expect that it should go to 100, but there could be other systemic factors that make, that impede this, but it's work that is going on, and we congratulate the team for the effort. So thank you very much. So that is all for the program overview from Kenya.
Thank you so much, Dr. Ryle, for sharing the highlights on achievements and challenges that the Kenya program has gone through. Amidst all that, we are happy to report the opportunities and the sustainability that is embedded in working closely with the national MOH and the counties. So now we'll invite Dr. Hawa from Nigeria. Okay. Hawa, you can just hold on.
Hello, everyone. I just need to make a very important announcement. One of our colleagues, whom most of you know, you must have worked with him before. Sadly, last night he passed away. He was in hospital, suffered a massive brain hemorrhage. Yesterday he spoke to most of us. He called me 30 minutes, full of life. Never could be more positive about what life has to offer or his treatment. And just this morning, we've got the message that John has passed on. He spoke to many of you yesterday. He called many people yesterday. When I saw the email, I couldn't believe it. I thought it was a lie. I had to make a phone call. But I think it was only fair to announce now before any one of you gets an email, because I think he was close to everyone. He goes above and beyond in anything he does. Yesterday he called to ask for the link to join this. So sad he could not be here. And he followed everything in the planning. He knows everybody in the team. So let's pray for the repose of his soul, and that God will comfort his family. And, for those of you who work closely with him, so the head of HR has asked me to pass a message that if you need any help, let us know, and then we will provide support, for you as you deal with this very sad news. I know Hawaii are speaking next. If you can't speak, it's okay. We can take a few moments. Can you do it? No. So maybe we can break for early lunch. Let's break for early lunch, and then we'll come back. I think it's okay.
I think we can break for lunch, then we'll come back at 1:10. Lunch is ready at 12:30, so we can take 20 minutes. May John's soul rest in peace.